Broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, welcome to the Fight Colorectal Cancer webinar. My name is Sharon, I'm with the Fight CRC team. And today we are talking about cancer and trauma, psychosocial distress and trauma in the medical setting. We're excited today to have Schuyler Cunningham join us to present this webinar topic. He is a social worker in the DC area. Also, at the end of the presentation, we'll have a lot of time for question and answer. During the presentation, if you have a specific question that you don't want to forget, please go ahead and type it in the panel on the right side of your screen. We can address those during the presentation and also at the end. If you want to watch the webinar after the session today, it will be living online at fightcrc.org/webinar. That should be up in a few hours, and you will also get an email tomorrow with a direct link to watch the webinar recording. We are on Twitter, so please follow along using the hashtag CRCwebinar and join the conversation there. Fight Colorectal Cancer offers a number of resources. We have a podcast series called Tabooty, where we talk about taboo topics. We have our mini magazines. Our latest edition is on screening and prevention. And also we have our clinical trial finder that you can find on our website. The information and services provided by Fight CRC are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. Fight CRC never recommends or endorses any specific physicians, products, or treatments for any condition. And finally, super excited to have Schuyler Cunningham. He's an award-winning social worker and researcher. He has a lot of experience in a variety of areas, including cancer and trauma. He's a sought-after speaker. He's published on various aspects of mental health counseling, including an upcoming paper on distress and traumatic stress in people with cancer. We're very excited to have him joining us today and talking about this topic specifically. And with that, Schuyler, I'm going to go ahead and make you the presenter and we'll get started.
All right. All right, so let me bring up the slideshow. Okay, can you see the slide?
Yes, looks good.
Okay, perfect. Hi, everyone. Thanks for having me. Looking forward to talking about this very important topic, psychosocial distress and trauma in a medical setting. So let me just dive in here. But let me say, again, if you have questions, feel free to type them in real time as they occur to you into the chat function. And if there are, we will spend some time at the end of the presentation reviewing the questions and giving my best shot at answering them. I am going to talk about some pretty nerdy literature stuff at some points. So if you have questions of clarification about those slides, please put them in real time as well. And someone will interrupt me if we really need to address one of those as we go. So here we go. Let's see, how do I switch the slide? Okay, here we go. All right, so learning objectives, we're going to describe the spectrum of distress-related mental health conditions, provide an overview of traumatic stress in the medical setting, describe the prevalence of distress and traumatic stress symptoms. That's what TSS stands for, traumatic stress symptoms, and I'll explain to you why we're using that terminology in a few minutes. And specifically looking at TSS and the oncology population and discuss a recent study that I did. So I want to tell you a little bit about myself. That's a picture of me and my wife. We like to do a lot of rock climbing. So we were rock climbing in Joshua Tree National Park, and it was actually really cold. And I had lost my sunglasses, so I had to buy these crazy sunglasses, but I thought people would enjoy that picture. I've been doing clinical social work in oncology settings for about 10 years now, and I also do private practice work where I'm an EMDR certified consultant, so that's a trauma-informed technique that I will talk a little bit about. And I also use neurofeedback, which is also, it's sort of this brain training biofeedback intervention. That's very good for trauma, among other things. And I would love to do some studies and see if this might help with things like chemo brain, help people get a little bit cognitive rehab going. So this, I have to be clear that while I do work at NIH, this study is, I mean, this presentation is not endorsed by NIH. I don't speak on behalf of the NIH. I'm just clearly speaking on behalf of myself. So I just have to say that. And I want to also tell you why I care about specifically colorectal cancer. That's my cousin, my uncle. That would actually be funny if he was my cousin. But his that's Uncle Shane, and he had stage 4 colon cancer. He's about 4 years out from treatment at this point, but I just found out last night that he's back in the hospital. So, you know, I care about this disease specifically because of Shane and my relationship with him and my family, but just also because of my work in cancer. So I wanted to just introduce you all to myself a little bit and my uncle. So let's dive in here. So we're going to map out some definitions. Distress, as you probably know, is a very common term and something that people look at a lot in the oncology setting. It's an unpleasant emotional experience that interferes with the ability to cope with cancer treatment. So this is not a DSM diagnosis. Distress is not a medical diagnosis, but it is a variable, and it's an experience that a lot of folks have while they're going through their cancer journey. So it's something that we'll talk about in terms of using as a variable to build on. Okay, so acute stress disorder is something that people tend to be a lot less familiar with. And it is a DSM diagnosis, it's a mental health diagnosis, and it's quite similar to PTSD or post-traumatic stress disorder, but a lot of the difference has to do with the onset of symptoms, that the symptoms are persistent for less than 1 month. Traumatic stress symptoms is a terminology that we're using to talk about people and experiences and symptoms of traumatic stress that don't necessarily meet the threshold of acute stress disorder or post-traumatic stress disorder. Post-traumatic stress disorder, people are probably quite familiar with. It's in the news a lot. And in fact, we see it on TV a lot more than you realize. Like if you watch Game of Thrones, there's a whole lot of PTSD going around on that show. But that's not to take away from it. I love Game of Thrones. But, you know, PTSD is what you'd think: nightmares, flashbacks, you know, unable to do work or engage in social relationships because of an overwhelming experience of traumatic stress. So I wanted to just lay out some of those terms because we're going to start building on these now. So distress in the oncology setting is pioneered mainly by the National Comprehensive Cancer Network, and they came up with this tool, the distress thermometer. Some of you might have even had it if you're survivors or going through treatment now. Nurses might ask you, social workers might ask you, how stressed are you on a scale of 0 to 10? Just like a pain thermometer. Then they might also give you this associated problem list. What's neat about this is the NCCN allows people to adapt and adjust it for their setting. So if they're in a specific kind of cancer clinic, they might want to change some of the things on the problem list, and the NCCN allows people to do that. So this is basically how distress is measured, which is really important when you start to talk about research, because you have to have a variable that you can replicate. And the distress thermometer is probably the one that people use most in the oncology setting. All right, so then distress can also be measured with this BSI 18, or the Brief Symptom Inventory 18. This is a pared down instrument that there's a bigger one that has a lot more questions, but to make it more accessible for people and to make it faster in, say, a screening context, people often will use the BSI 18. It's definitely more robust from a research point of view because there are a number of subscales like depression, anxiety, hostility, and you can, as a researcher, you can sort of peel apart the numbers and understand where people might be coming from, what might be driving their distress, which is important. As you see, there's no problem list here. Whereas on the distress thermometer, you know, you might say you're distressed 9 out of 10, and it's because you're having a hard time with fatigue, transportation, and depression. One of my favorite responses was when someone wrote, I'm in Washington, D.C., and there's a big rivalry between the Redskins and the Dallas Cowboys, and someone put a 0, they said a 10 out of 10 because the Redskins lost to the Cowboys over the weekend. So you never really know what folks are going to say. And the BSI 18 doesn't really give you that problem list, but it does have subscales, which can be really helpful for understanding what's going on. The other drawback to the BSI 18 is that it costs money to use. The NCCN's distress thermometer is free, whereas this one costs money to use. So it's often really used mainly in research settings because it's not cost effective for a general large population if you're just doing a lot of screening. So I want to talk a little bit now about psychosocial distress and the prevalence. So the literature tells us we know it can be debilitating. We need the literature to validate that from a sort of research peer review point of view. But if you just talk to people who are going through the process, you can see right away how distress can be debilitating. There's 30 to 43% of prevalence in distress across 14 different cancer diagnoses. This was an article published by Zabora et al. In 2001. And it had a massive sample size, I think in the thousands. I think it was either 9,000 or 10,000 people. And they broke it down per cancer. And I think relevant to this group and our conversation today is 32, the prevalence of distress in people with colon cancer of 32%, according to the Zabora article. So that's 3 in 10. And to me, that's significant. So then since 2015, the American College of Surgeons requires all accredited cancer hospitals to screen for distress. Now, you might be thinking if you've either a caregiver or maybe a provider or you've been a patient yourself, maybe you weren't ever asked. And I have another slide in another presentation that shows that actually, while this is a requirement, the implementation is still around 55%. So it's still not completely rolled out across the country in cancer centers that are accredited by the American College of Surgeons, but it is a standard, and I think that is important to let people know. So how distress affects us. This again comes from the literature, which is more of what I'm going to stick to today. But it can decline in treatment adherence, and that can be quite dangerous in many ways. So for example, if someone has a symptom that they might fear is a reoccurrence, they might not go back and get worked up because they're too stressed out to do that. Can't fault them for that, right? Because it can be very, very overwhelming. But this distress can basically be life-threatening in that sense. Barriers in communication between patients and providers. I'm sure that we're all quite familiar with this, as little as we want to be. But if we're stressed out, oftentimes this manifests like, I'm the social worker, I'll go talk to patients and their caregivers, and they'll have a beautiful list of questions. They'll want to have lots of detail. Maybe they've done some extra research on some of the treatments. And then the doctor or the provider walks in and like, boom, it just flies out of their mind. And they're just like, I forgot. So that can be a barrier. People don't feel like they're being understood or heard, or their symptoms are being taken into account, or even they're being trusted. And so distress can be have a pretty big impact on that. Increasing healthcare costs. This is another side of the distress where people might get a cold or a cough or have another symptom that they become a bit hypervigilant about, and then they're always in the clinic trying to figure out what's going wrong, or like bullet 1 here, when they don't show up and things now progressed a little bit further, the cost of their care becomes more. It wasn't caught earlier. This isn't to blame or shame anyone. This is really just to describe the effects of distress. And of course, poorer quality of life, because if we're stressed out, we're probably not eating properly. We may not be talking to our loved ones. We might not be doing things we enjoy. We might be sleeping more or not sleeping very well. So in other words, distress can have a pretty debilitating effect. The impact of distress, and this is where I'll just introduce this term CRTS, which stands for cancer-related traumatic stress. And we're going to start building on distress and moving towards understanding traumatic stress. People can have intrusive thoughts and nightmares, flashbacks. I'm not going to read the whole slide here. I put this mainly just for a reference for yourself, or if you're a caregiver, for sort of things to look out for, or provider things to screen for. these can be quite significant and debilitating as well, and they may even point to, PTSD that needs to be worked up and treated appropriately. So I really just put this slide out here more as a reference point that I wonder if people are sort of shaking their heads at this, like, yeah, I've had some of this, or I've seen people with this. So we'll keep moving on here. The literature also talks about most stressful moments in a cancer journey. Oftentimes it's the diagnosis, restaging, or evaluation. I'm sure you've heard of the term scanxiety, where people can get really, really tweaked out right before a scan. Oftentimes it can take a couple days to have a scan read, and that time frame in between the scan and the result can be also very stressful for people. We talked a bit about provider communication. Procedures is the same way. Colonoscopies, for example, can be quite distressing for people. Not to make this very morbid or gross, but especially if, say, they're a sexual assault survivor and now they have to have colonoscopies, this can be very debilitating for them. Bone biopsies can be quite painful, etc. And then telling family and friends, this is a really important one that's hard to overlook, that moment where we have to tell maybe our children or our parents or our newly married partnered spouse that, we have cancer, is also often reported as one of the most stressful moments for people. All right, so we're going to move and talk a little bit about PTSD now. So we're trying to build here on distress, and then we're going to talk about PTSD, and then we're going to come back to just talking about traumatic stress symptoms. The reason we're talking about PTSD here is because PTSD is a validated medical diagnosis that has certain criteria that can be replicated in a research study. Traumatic stress symptoms is not that. So we need to look to what the standard is before we can sort of look at what could be a sub-syndrome or another way of looking at traumatic stress exposure. So incidence of PTSD in the cancer population following the end of treatment range from 3 to 32%. So why such a big range? There's such a big range because study designs vary, sample sizes vary, the measurements that the instruments that people use to collect information about post-traumatic stress disorder diagnoses can vary. And so you have this wide range, but if we just cut it in half, 15 or 16%, that's still quite high. PTSD in the general population is not 15%. So it is important for us to keep that in mind. Fully diagnosed PTSD in early stage cancer was really 3 to 4%. And that's in a 2012 study. So that's relatively recent. But following treatment, it goes up to 35%. That's a little bit of an older study. But, one reason why this might be happening is post-traumatic stress disorder focus on the post, right? On the symptoms that happen after the event has occurred. In my experience working with folks who are going through treatment, oftentimes once they get the diagnosis and they kind of put their nose to the grindstone to execute the treatment plan, they muster all their resources, emotional coping strategies to get through treatment, because their life is on the line in many cases. And it's only when and if someone gets to that survivorship phase, or they get into like a bit of a lull of a treatment or a treatment break, that they can start to let down some of their defenses and sort of take a step back and say, holy moly, what really did I just go through? What really just happened here? And that's when a lot more of the symptoms start to emerge and present themselves. I think another thing that's important to say, a lot of the PTSD literature in oncology is from breast cancer population. There's a lot of money in breast cancer, as you all know, and so there can be a lot more research. So just knowing that might be helpful. And we'll keep going here. All right. Risk factors of people to develop PTSD. I put this in again as a way for you to kind of wrap your brain around like things to look for, whether or not you are a patient, you're a caregiver, or you're a provider. So 39 studies between 92 and 01 found that known risk and protective factors in other trauma contexts are relevant to cancer. That's important because we can't just assume or think that people come to the clinic and receive a cancer diagnosis and they haven't had traumatic stress exposure throughout the course of their life. Unfortunately, traumatic stress can build, and it's important to know that the literature suggests that the protective factors can also help people who have cancer. And we're going to build on that a little bit later. So most common of the risk factors are female young at diagnosis. SES stands for socioeconomic status, and a couple other things here. So importantly, significant reduced quality of life, even if temporary. Oftentimes this will occur after surgeries, where somebody has to do a fair amount of rehab, maybe adjust to an ostomy or some new sort of hardware or new physical process that they have to undergo. So oftentimes that reduced significant quality of life can happen, and people can become heightened levels of distress after surgeries. Cancer-related traumatic stress, we're back. This is the term. We're going to talk a little bit about sort of when this often pops up. So I used to work in a clinic where after the physician went in to give the diagnosis, the positive diagnosis, they would send me in. And I often, remember seeing the physician deliver the diagnosis, and then the patient would pretty much go into a state of shock. They wouldn't remember what the treatment plan was. They wouldn't necessarily remember the stage or the kind. So that's a moment, if you've seen that or witnessed that or experienced that, you might have a visceral experience of what I'm talking about here. So I put that in there, just try to jog your memory and give you maybe even a felt sense of what that moment can be like in terms of cancer-related traumatic stress. It's also not as severe as PTSD. It can be, but it's not necessarily across the board as severe as PTSD. In PTSD, there are a couple different gradations of diagnosis. So it's important to sort of understand that PTSD is not just one thing. Likewise, cancer-related traumatic stress is not just one thing. And generally speaking, cancer-related traumatic stress is considered to be less severe. The other important thing to know is it can occur at any time. So while I spoke a little bit about the post or the onset of these symptoms after treatment or during a long treatment break, it can really occur at any time. Okay, just check my time here. All right, good. So we're going to talk a little bit about the prevalence of cancer-related traumatic stress. So again, we went from distress to PTSD, and now we're sort of moving back down to cancer-related traumatic stress, which is not PTSD and is not really a mental health condition that's diagnosed, but it's something we're working on. So cancer diagnosis is a threat to life and bodily integrity. That's often, if you don't get a cancer treated, you're likely to die from it. Even slow-growing indolent cancers like a follicular lymphoma or some like a pre-myeloma, these things might take a while to grow or to populate, but ultimately it's a threat to life. That's one of the hallmark definitions of traumatic stress, is somebody thinks their life is at risk or they're under threat. It overwhelms someone's capacity to adapt, their capacity, overwhelming a patient's adaptive capacity consistent with traumatic stress exposure. In other words, cancer-related traumatic stress does this. And so we wanted to put that in there to just continue to solidify this idea that cancer as an antecedent or as a cause to traumatic stress is validated. Then symptoms of traumatic stress. So again, this is not PTSD, but this is traumatic stress symptoms. That was on the earlier slide. We sort of looked at a few of those symptoms. The literature is showing 20% with early stage cancer. So you remember 3 to 4% had PTSD in early stage cancer, but 20% have traumatic stress symptoms in early stage cancer. And it goes as high as 80% in recurrent disease. Recurrent disease is unfortunately something we see more often than we'd like to, but that's 8 out of 10 people. And that to me is an incredible epidemic. and something that really, this is why I'm passionate about this. We need to do something to help people deal with the traumatic stress they're experiencing, especially if they have recurrent disease. And you might, like, one good way of thinking about that is anybody who has to usually have to have a transplant or a bone marrow transplant, they often have to get a transplant because their disease doesn't go away in the first place. Okay, so what we're doing, so we created a study because we wanted to look at, we wanted to try to demonstrate that traumatic stress symptoms among the oncology population was a thing. And there is some literature that we've just reviewed, but it's still not clear enough in the literature that people are, like, hospital systems or clinics are willing to sort of say, okay, this is something we really need to screen for, or we need to, or even mental health folks are saying this is something we need to refer for trauma-informed mental health care. This study was really born out of a couple cases that me and my colleagues had, where we had some folks who were coming in for mental health care, and my colleague was doing some cognitive behavioral therapy with them, and it wasn't working. And in fact, the person was getting worse. So we did a case consultation to try to figure out what was going on, and it became clear to me that this person was exhibiting trauma symptoms. And CBT alone is really not indicated for trauma. You can use trauma-focused CBT, but just general CBT wasn't working. So basically what happened was the person would come in and say, you know, therapist, I'm doing everything that you told me to do, my CBT homework, I'm coming to meet you once a week, and I'm getting worse. And what she said, her conclusion was, it must be me. And that really rocked me, right? That somebody who's earnestly working as hard as they can to better themselves after she had a lymphoma that came back, and then she had a bone marrow transplant, really felt like her life was sort of doomed, that somehow she was cursed, that she was the reason all this bad stuff happened to her. And so this is where the study was born, and we said we need to really work on this. So what we needed to do was we needed to explore the relationships between distress and traumatic stress symptoms while we controlled for a lifetime of traumatic events. So this is why I sort of walked you through distress, PTSD, and back to cancer-related traumatic stress. It's because we're not necessarily trying to show prevalence of PTSD. That's out there. What we think, and what I think, is that there's a bigger subset of the population who's going through oncology treatment that does not meet the criteria for PTSD, but has more than distress because they have traumatic stress exposure. And as a result, we need to take that traumatic stress exposure seriously, because treating traumatic stress is something very different than just treating distress. So let me walk you through some of the ins and outs of this study. This is where things are about to get really nerdy. So feel free to live chat comments, and we'll try to answer them as best we can, or live chat them and we can try to answer them at the end, especially if you have a clarifying question. So what we did with the study is we used the stress model theory, and I'm going to detail that in a couple slides, in the next slide here, so that you can understand where this comes from. It talks about, the stress model theory talks about how emotions are generated. So I'll show you a graphic in just one second, and that the outcome of that is stressful event. In our case, we were making the argument that it manifests as psychosocial distress and traumatic stress symptoms, what we're calling the emotional reaction. So this is just really nerdy sort of psychosocial theory, a theory base that we need to inform our study to explain why we think this is a thing and how we think this thing is being created. So here's a graphic that we made that talks about the stress model theory. Emotional reaction is lifted a bit in the center there because that's sort of the outcome, right? So we have these different categories: person factors, situational factors, predisposing factors, and cancer experiences. And anything that causes, that, you know, influences these different these different factors can influence someone's emotional reaction. We talked about the predisposing factors as risk factors earlier. Age, gender, marital status, orientation, education. So these can generate emotional reactions in relationship to cancer. Person factors, their vulnerability. In other words, is this a elderly person who's single with no health insurance, no transportation, etc. Surface versus depth, sort of like how this person is coping and what kind of experiences and coping resources they have. Belief systems, you know, some people with spiritual beliefs, there's some literature that shows people with spiritual beliefs cope better. That's not necessarily the case across the board, but we're looking at these different person factors. Locus of control is really in reference to a psychological term that figures sort of like where someone acts from. Like that's a nerdy side point. I'm just going to move on. Sorry. Situational factors. Like, is this a new diagnosis? Did someone in their family have, let's say, breast cancer, and they got the BRCA testing, so they had an idea that it might also be their experience. So maybe they thought a little bit about it, or maybe they didn't. And of course, the types of cancers, stage of cancer, the time since the diagnosis, and in clinical trials, and the types of treatment. So, I mean, you're probably familiar with chemotherapy, immunotherapy, surgery, radiation, and all these different types. But with certain kinds of cancers, they can be much more brutal. With colon cancer, for example, having a colostomy or an ostomy bag can be a very major change. In cervical cancer, there's this thing called brachial therapy, where they actually insert radiation rods intravaginally, and women are required to stay put in a hospital bed for a day or two at a time. They're not allowed to even go to the bathroom, and they get zapped with their radiation every so often. That to me sounds like torture, but it's the treatment. And so I'm just trying to draw a spectrum here that types of treatment can have a very significant impact on someone's emotional reaction. So what we did in this study was, I'm gonna just take a deep breath because that's some really heavy stuff. All right. What we did was we had the NIH Clinical Center patients participate in the study, and we used the BSI-18, which we discussed a little earlier. We used the Life Events Checklist, which is a free tool. We'll talk about that in a minute. We used the PTSD checklist. We did a demographic survey because we needed to collect some additional information, and we used medical record data. So after the patients consented to the study is when we were really able to access the data, just to make that clear. We used an exploratory model with cross-sectional study. So we were just kind of looking at, just trying to explore the existence of the phenomenon. We had our independent variables as level of distress and lifetime trauma. So we were controlling, as I mentioned earlier, for events that are known to cause traumatic stress besides cancer. So we'll talk about the instrument that we use for that and how we use that. But I think you can appreciate that we can't just make this jump that if someone has cancer, that the traumatic stress is caused by their cancer. It might not be. It might be caused by something else that happened in their lives previously or during their cancer treatment. So we have to try to figure that out as well. And then for level of traumatic stress symptoms, we used the PCL5. We'll look at that in a second. Then we added some covariants, which came from the medical records, date they were diagnosed, number of treatments, types of treatments, those kinds of questions. And then we used a multiple regression analysis, what we'll get into later. All right, so how is traumatic stress measured? In our study, we used the PCL5. I know this is small and hard to see, but you can get this tool for free on the VA's website. It was developed by the Veterans Administration, and it's according to the DSM-5 criteria for PTSD. So we use this measure because it's up to date, it's well validated, it's quick, so patients didn't have to take a lot of time filling it out. But I want to point out a couple things about this, because this isn't, while it's one of the best measures out there, I got frustrated with it, and I think you'll see why. So it's a Likert scale, which means, 0 to 5, over the past month, remember, we talked about symptoms being persistent for about a month when we were talking about definitions earlier. So that's the time frame there. There is a clinical cutoff for this for PTSD screening, but since we weren't doing it from a clinical point of view, we weren't really adhering to that. And I want to sort of explore a little bit of some of the frustrations here. You can see the limitations of research when we do this as well, also the value. So the prompt is, in the past month, how much were you bothered by sort of ... How much were you bothered by? And that each question gives you a specific one. So I'm just going to read off number 1. In the past month, how much were you bothered by repeated, disturbing, and unwanted memories of the stressful experience? But we were talking a little bit earlier that the stressful experience is really hard to isolate. So while this tool is helpful, this tool also doesn't really help tease out what that stressful experience was. So that's kind of a limitation of the study and a limitation of this tool, but it was also like one of the best measures we could find and use. So we used it, but I wanted to point out that limitation to you. All right, LEC 5, which is called the Life Events Checklist 5 corresponding to the DSM-5. This is also free, and it's also available from the VA. I'm sure if you just Google it, you'd be able to find it. This is how we controlled for lifetime events known to cause traumatic stress. So there are a couple things to recognize. Number 1, this is the time frame for this instrument is over the entire lifespan, whereas the previous one was the first 1 month. This is over your entire life. There's 6 possible answers, so there can be multiple answers for each question, whereas the PCL5, we only want 1 answer per question. The possible answers, I'll read them because I know it's hard to see, is that it happened to me, I witnessed it, I learned about it, it was part of my job, I'm not sure, or it doesn't apply. So you can see there how you can have more than 1 answer. I want to point out a few items on this questionnaire. Number 5, exposure to toxic substances, for example, dangerous chemicals or radiation. So if people are getting chemotherapy, that's toxic. People are getting radiation care, that's toxic. So just sort of getting you to understand how some of this overlaps a bit with what we were specifically looking for. Number 12, life-threatening illness or injury. And number 13, severe human suffering, which can be that way. Cancer treatment can be that way for some folks, and even being a caregiver can be that way for some folks. So this is the LEC. This is the instrument that we use to control for traumatic stress over the lifespan. Our research we had 53 folks in our study. 81% of them were male and 74% of them were white. That's really reflective of the clinical trial population. And one of the diagnoses we included was prostate cancer. We had prostate, mesothelioma, lymphoma, and leukemia. And we did that because those populations are underrepresented in the literature. It gave us a good mix of people who are going to get surgery, radiation, chemo, and immunotherapies. So average age was 56. So this is just little descriptions of the sample here. All right, so the diagnosis sample, as I mentioned, the different kinds of cancers, and here's where you break it down in terms of how it broke out per diagnosis in the sample size of 53. And one thing I want to point out here is that when we ran our model, we found that the oncology diagnosis was not statistically significant in relationship to traumatic stress and distress. So that might be because our sample was smallish, but I just wanted you to know that as we keep going forward here, the diagnosis ended up not being significant. The different kinds of treatments our population received: immunotherapy, chemo, surgery, radiation, hormone, and we did have some bone marrow folks on the study as well. So just giving you this snapshot, I think in a clinical trial setting, immunotherapy can be a little bit more typical as they're a little more experimental, which might explain why we had a higher percentage of that. All right, results here. It's the number of treatment modalities. In other words, did someone get chemo and radiation, or chemo and surgery, or surgery and radiation, etc.? So as you see, most of our population had 2. And if you put 1 and 2 together, you get an overwhelming majority. And then just wanted to point out that 43% of the sample was in active treatment, and the other were either pre-treatment, pre-treatment but diagnosed. That's probably some of the prostate folks who had a diagnosis but yet hadn't yet had their surgery, or people who were done with cancer treatment and in their follow-up stage. So we thought that this might also have an impact, but it didn't. All right, so we talked about the BSI 18 earlier. I just wanted to show you again one more time because I'm going through the specific instruments in the study. So I'll just keep moving here because we chatted about that earlier. So clinically significant distress on the BSI 18 draw your attention to the bottom left of the slide here. There's a clinical cutoff of 10 for men and a clinical cutoff of 13 for women. So in our sample, was 30% men and 20% women. Wait, sorry, that doesn't quite add up. So okay, so that's right. So it's 30% men who were met the clinically significant level, and 20% of women who met the clinically significant level in our sample. The literature says, as we looked in colorectal cancer, the average is 32%. So with men, if we use that as a proxy, with men we were about at the same as the literature, and women we were a little bit lower. But if you take it all together and that total number 28, we were our data was pretty close to what the literature has said historically. So that's just a good indicator that we feel like we were on track. Summary of the BSI scores here. So no one answered positively. One of the questions on the BSI has to do with whether or not you think you've had thoughts of taking your own life. So that's a scary question to ask in a research study. But I wanted to let you all know that no one answered that question positively among the 53 people that answered it for us. Another interesting tidbit is our bivariate analysis, where we just compare two variables to each other, found that the level of distress and the level of traumatic stress symptoms had a significant positive relationship with a p-value of 0.0001. So that's starting to show that, you know, there is a statistically significant relationship between distress and traumatic stress symptoms. We talked a bit about how we control for past events, the things that oh yeah, I think this just might be a duplicate slide. All right, so, oh yeah, to talk about the LEC, just to give you a reminder about what that looks like, and then to talk a little bit about the detail of the summary. So this one was a bit tricky because you might remember that people could have 5 answers and you could have multiple answers per. So I'm giving you the mean score, in other words, frequency of people, how many each, on average, how many items subjects is basically acknowledged by checking the box. So that was 11.5. So let me give you a little bit of rundown of what that actually meant. So in the bivariate analysis, it showed a statistically significant positive linear relationship, which just means that it's really important, between happened to me. So if we go back here, this first column here, like a natural disaster, fire explosion, transportation accidents, etc., that it happened to me, was related to traumatic stress symptoms. So the more often a participant answers affirmatively to happen to me, the higher their traumatic stress score was likely to be. Also, we found a statistically significant linear relationship between witnessed it and traumatic stress. So going back here, if it happened to them is one piece, but if they witnessed it, it also had a relationship to traumatic stress. So the associations between learned about it and part of my job were not statistically significant in relationship to traumatic stress. And the number of traumatic events across the lifespan and traumatic stress also had, so this mean, an overall score also had a significant relationship to traumatic stress. Okay, so I know that's a lot, but we had to break this instrument down in some pretty important ways to really get the most out of it. So now back to how we measure traumatic stress, and we talked about this earlier, so I'm just showing you this again so that you can see it. So the summary here, again, let me switch my paper. The summary here is the PCL5 has the clinical cutoff of 33 out of a possible 80. So if someone scores a 33 or higher, then it's indicated that they should be worked up for PTSD. I'm going to move a little bit faster now. So the bivariate analysis, really the big takeaways were the level of distress and level of traumatic stress symptoms did have a significant positive linear relationship, and the number of lifetime traumatic events and traumatic stress also had a significant relationship. And this multivariate analysis is really where we kind of get fancy. It's when we put all the variables together in the same model and test the different combinations of variables. So there was 23 variables that ultimately got included in the model, and I just punch out ECOG here, which stands for the Eastern Cooperative Oncology Group. It's a measure of performance status. Only 13 of our people completed that, or it was in their medical record. And we tried to use this as a proxy for medical acuity, but we didn't have enough data to really use it. So in the multivariate analysis, what we found was that psychosocial distress and marital status and traumatic stress symptoms had the most statistically significant relationship. That the levels of distress and marital status explain about 57% of the variance. This means that people who are not married and had higher levels of distress were likely to have traumatic stress. Now, just a side note, we're not measuring the quality of the marriage, just that they were married or not. And remember that the sample was 81% men. So that might be important to just keep in the back of our mind as we're thinking about this. One really last cool thing. So what we found was that 1 point increase in the BSI, which is the measure of distress, was associated with 0.67 points increase in the PCL score, which was our measure for traumatic stress symptoms. And that on average, participants who were married or partnered had 4.4 points less on the PCL5 than those who were not married. So this is really interesting because if you can start to do, I mean, this sample is kind of small for this, but you can start to see there's a ratio here. So if someone scores a 50 on the BSI 18 out of 72, they might just need to be worked up for traumatic stress right away. Or if you give someone just the PCL and someone scores a 33.5, then you know that they are also highly distressed. So, I mean, we can't really create those ratios as a definitive outcome, but I think it's really important. So we talked a little bit about this. We know that these are mainly clinical trial patients, so they may be experiencing more than is currently identified. That's just to clarify that the sample size was all clinical trial patients. And screening for distress may help people become more aware of the symptoms and lead to better interventions. So how can staff help? I'm going to make a shift here now, and I'm just moving a little bit quickly because I know people probably have some questions, so I want to get through this. So the education of interdisciplinary staff, whether you're a patient or caregiver or provider, you can always teach the staff about what to look for. You're going to have the slides and some more information about what to do. And my role is also to educate medical providers, as much as it is to provide clinical care to people. And then inpatient or in a hospital setting, it can be hard to do one-on-one therapy. So it's often really helpful for hospital staff to be a bridge to trauma-informed care in the community. Here's a few general screening questions you can ask. This again is just like a way to, it's kind of a repeat of one of the earlier slides, but I wanted to bring that back to your attention here. Treating trauma in the hospital setting can be pretty difficult because it's hospital settings are quite chaotic and busy, but knowing about these symptoms, knowing about these studies, knowing about these numbers can help you contextualize someone's symptoms with them, and that can be very, very stabilizing. That's also a way of helping someone kind of contain where they're at, so they're not spinning as much. They might have a frame for what they're going through, might have a treatment plan or a path forward to get some trauma-informed mental health care, and again, be a bridge to therapy. A couple things to know about trauma-informed mental health care is at its core, it's an exposure therapy, which means you have to in some way discuss what happened. But the therapist has to help you do that in a way that's safe so that you don't kind of get re-triggered, or that they say remember, not re-experience. It's based in neuroscience, where this Body Keeps the Score book by Bessel van der Kolk is sort of seen as the godfather of current day trauma theory. And one of the catchphrases they say is the issues are in the tissues. And what that means is that traumatic stress is primarily a physiological experience, that it has to do with the way that our memories and our fear systems are activated in the brain, and how during traumatic stress response, parts of our brain can play a lot less of a role, and connecting the different parts of our brain to resolve the triggers and the emotional experiences and the physiological experiences we have in relationship to trauma is at its core trauma-based therapy. That's why it's body focused. And this is the example of I'm kind of going crazy, where someone might be in an environment, they get triggered, but they have no idea what it was that caused that trigger. That's because another part of their brain is watching for them. And when that part of their brain sends the red flag, then their whole body and their whole mind shifts. So these are some pretty important distinctions about trauma-informed mental health care that I just want to bring to your attention. Some ways to get this treated, as I mentioned before, trauma-focused cognitive behavioral therapy. Eye movement desensitization and reprocessing is also an important intervention. Just to note, some people find that to be controversial because it's hard to figure out why exactly it works, but that's sort of a bigger problem in psychology across the board. And neurofeedback, I mentioned earlier too. Neurofeedback can be a really important brain training biofeedback intervention for people with trauma, even if they don't have PTSD. So here's some resources for finding a therapist. Psychology Today, Therapy Den, which is a newer and it's a pretty neat one. And emdria.org is they've got a find a therapist EMDR practitioners on their website. And I try to highlight here, so in Psychology Today and Therapy Den, you can actually search and filter for people who have specialties in trauma-focused or PTSD. Okay, I'm gonna stop there and thank you all for your attention and time, and I'm definitely excited about some questions.
Thank you so much, Schuyler. What a great presentation. I'm going to go ahead and take the control back from you here. So let me go ahead and give me just a moment. Okay, so we'll go ahead and kick off with some questions here. To those of you that are listening in live, please go ahead and type in your questions on the right-hand side of your screen. And give me just a moment. Hold on. Here we go. So what should a patient do to make sure that they have access to mental health support? I know that you just listed some resources where people can go to seek a mental health professional, but is there anything else that someone should do at the time of diagnosis to make sure that they have access?
Oh, well, yeah, certainly. I mean, if they already have a mental health provider, they can certainly connect with that person again. Ask the clinic to provide recommendations for mental health providers. Oftentimes clinics have referral lists. You can search those resource sites that I just provided and see if there's a nurse navigator, a social worker, or a mental health professional in the organization that can point you in the right direction. There are a lot of cancer support groups, and those are very helpful for a lot of people, and those also some people prefer more one-on-one. So I would say, you know, you got to be persistent in asking for what you want from the medical providers, but those are probably your best resources to start with.
Great, thank you. Let's see our next question. This is coming from a survivor who, when they walk past their local cancer center, gets kind of a visceral reaction. Aside from going a different route, what are some things that can be done to help manage that?
Yeah, that's a really good question. That I get that question a lot. Also, like if people have chemo and they're getting a flush or they can taste the heparin in their mouth, all these sort of visceral experiences. That's a great example to show how the issues are in the tissues. So what I would probably recommend EMDR for that, because that's a trigger that can be desensitized. It's not quite a phobia, but you might, if you're willing to put it in that category just for the sake of discussion. Phobias are often through exposure therapy as well, through graded exposure therapy. So EMDR is a good way to do desensitization work. That's one thing. I would definitely, you know, get someone's help for that, because if you just keep walking through, it actually could get worse, and I wouldn't want that.
Great, thank you. Yeah, I imagine you mentioned that you hear a lot of that from the patients who you see. Is that a fairly common response?
Yeah, that's very, very common. I think that's important to say, is that this is one way that our body stores these memories, so that when the sort of get a little nerdy here, but the amygdala part of our brain is one of our sort of fear centers. It says danger, danger, and it's not necessarily directly in conversation with the executive functioning parts of our brain, which is more in the frontal lobes, the neocortex. So that disconnect where you might just be on a walk, hey, I'm just going to go on a walk, or like I'm just going to go pick up some medical records, or I'm not even here for any kind of treatment, any kind of labs, anything like that. The amygdala brain is still like, uh-oh, nope, last time we were here, this was not good. So basically working to desensitize that amygdala response is something that I hear a lot. Definitely, very common.
Thank you. So our next question, you keep mentioning the issues are in the tissues, or this kind of being a trauma is stored in the body. So would a practice like yoga or Tai Chi or meditation or these kinds of exercises that are intended to get you, it out of your mind and into your body, are these things that can also help with managing trauma?
Yeah, certainly. So when the nerdy speak again, we talk about affect regulation. How is someone managing their emotional experience is what that means. And so if mindfulness-based therapies, yoga, even just exercise, having a nice chat with a loved one, walking your dog, whatever, having a nice cup of tea or something, these might help calm us down, right? The thing is that the way that trauma seems to operate is that if we get into a hypervigilant state and our body becomes used to that hypervigilance or activated nervous system state such that we're on guard, great example of this is the meerkats on like one of the David, whatever that famous British guy is who does all the Planet Earth shows. They're always on guard. They're always watching. Someone's always watching. If our nervous system becomes used to that as a baseline, it's going to expect that. And the reason why that's important is because if there are plenty of times where people become relaxed and that triggers a trauma response, because now their nervous system is more comfortable or more familiar with a state of hypervigilance. So these relaxation exercises can work very well, and they can also be dangerous. And I don't mean to say that word lightly, and I'm not trying to say like yoga is dangerous, but what I'm trying to say is that if we have true traumatic stress exposure and we are struggling to deal with that, relaxing too much can also trigger a response. That's something that's very counterintuitive, but is a very good explanation for how the issues are in the tissues. So if it works, if mindfulness-based stuff works, if yoga works, definitely do it. If you're starting to notice some anxiety or some panic or some like just not feeling quite the way you want to feel, take that very seriously, because your body might be saying, hey, we need a little bit of help here, and we know you want us to relax, but we're not really quite ready yet. So I would probably seek some mental health help in those contexts.
Thanks, Schuyler. We have two more questions. Based on the presentation, it sounds like there's a lot of research going on right now for cancer patients and survivors. Have you seen much in terms of research geared towards caregivers and those that are like close loved ones?
Yeah, there's a fair amount of research on caregivers as well. Caregivers can have traumatic stress as a result of being a caregiver. So yeah, there's plenty of research on that as well. Cancer.gov is a good site for that. And there was a great study done by Dr. Margaret Bevans on caregiver stress in relationship to caregivers of bone marrow transplant patients. So that's some pretty seminal work out there. Again, that's Dr. Margaret Bevans. She's a nurse. She's excellent.
Thank you. And our last question, I think, let me check. Yep, our last question is about your next steps for the research that you're working on.
Oh, thanks. That's a beautiful question. Thanks for asking. Yeah. So I was starting griping a little bit during the presentation about these instruments, and these instruments that we use to collect data, as you guys heard me say, I wasn't completely happy with them. So what I came to my mind was they are the best instrument, or they're the right instruments, but not the best ones, or something like that. So the Cancer Trauma Project is a completely separate project where we just went back to listening to people's stories. So what we're trying to do is understand from just having them share their stories with us about where and how cancer-related traumatic stress really presents. So we just finished, we collected about 50 stories from people, and people can check this out on cancertrauma.com. And we just had some writers from the Columbia University School of Narrative Medicine help us write up the the interviews, and we're polishing those now and hope to release those at the end of the summer, early fall. And from that, we're also learning a lot about how to talk to people about this, trying to build a different way of understanding like a psychometric instrument we can use to collect this information, because not everybody has an hour and a half to talk to us. Certainly hospital systems wouldn't do that. But so using the Cancer Trauma Project to get back into people's stories, and from there build out some better understanding, better ways to teach other providers, caregivers, and survivors about what this phenomenon is, and hopefully build some better instruments to measure it so that the research can be better also.
Awesome. Well, thank you so much, Schuyler, for a great presentation. Really informative, great work that you're doing. And I know that this is a topic that really touches a lot of people that are going through a colorectal cancer experience. So again, thank you so much for your time, and thanks to everyone listening in.
Yeah, thanks so much for having me.
Thanks. Have a great day, everyone.